My name is Sabine Ostrowski. I am an optometrist and the National Manager of Healthcare Relations at the Macular Disease Foundation. Welcome to MDFA's first accredited webinar for pharmacists, a discussion on age-related macular degeneration, which will be led tonight by Dr. David Hilford, who is an ophthalmologist as well as a member of the MDA Medical Committee. Before we begin, I would like to, in the spirit of reconciliation, acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Before we start, there's a little bit of housekeeping. As with most webinars, you will notice that your camera is turned off and you are muted. If you would like to answer questions or ask questions, we would love you to. Please put those in the Q&A box and we will be coming to those at the end of the webinar. This evening is accredited by APC and the learning outcomes you can see listed there. And you can find the links to the multiple choice questions for accreditation either via the Guild Ed or ACP in the chat box. So if you would like to access those now, you can go into the chat box, click on those links and make sure your attendance tonight has been recorded and that you get the points. So tonight we will be joined by Dr. David Hilford. David is a Brisbane trained ophthalmologist who subsequently undertook retinal fellowships in Auckland, New Zealand, and at the prestigious John Radcliffe Hospital in Oxford in the UK. David has subspecialist vitreoretinal in Brisbane and Toowoomba, a member of the MDFA committee, and tonight we'll be presenting an overview of AMD. Our second speaker is Geraldine Moses. Associate Professor Geraldine Moses AM is a Doctor of Clinical Pharmacy specialising in drug information and is also Adjunct Associate Professor in the School of Pharmacy at the University of Queensland. In 2019, Geraldine was made a member of the Order of Australia for her work in medicines information and education, and tonight she will be presenting the pharmacist's perspective and on supplements appropriate in AMD management. But firstly, I would like to welcome David Hilford.
Thanks Sabine.
David.
Again, thank you for finding that picture of my younger brother to put up on tonight's panel. And welcome everyone, and thank you for your time this evening. And I'm going to talk to you about age-related macular degeneration. And I realise everyone probably has a different level of familiarity with this topic in terms of what they already know about it. But I thought I would take it back to ground zero and just make sure everyone knows the full basic details about ARMD. And I apologise, but those screens aren't advancing. So I'm just going to try something a bit different. Right, we're underway. Sorry about that. It just wasn't advancing. So what is ARMD, age-related macular degeneration? The important thing is that it's still the leading cause of legal blindness and severe vision loss in Australia. For working Australians, that actually is diabetes that's the leading cause of legal blindness, but on pure numbers alone, the age-related macular degeneration still leads the list in terms of legal blindness in Australia. 1 in 7 people over 50 have some evidence of macular degeneration, and its incidence increases with age. That's why we refer to it as age-related macular degeneration. it's important to know the actual definition of legal blindness, because for patients, a lot of benefits depend on this. Taxi subsidies, assistance from Centrelink will only be provided if the government deems someone as legally blind. And as a College of Ophthalmologists, we always tell the government that this high jump bar is way too high, in that the patient has to not be able to see the top letter on the Snellen chart in both eyes. So legal blindness is quite severe, and people need assistance well before then, but unfortunately can only get it when they reach that level of poor vision. And then 612, the other end of the chart, is drive-in vision, and of course 6/6 normal vision. The important thing with the Snellen chart is that it's a proper backlit chart at the right distance. Like a piece of cardboard on the wall doesn't really cut the mustard for measuring someone's Snellen acuity. So a reminder just how the eye works, that light comes in through the cornea and is focused by the cornea and the lens onto the retina, which is the film in the camera, and then the image is transmitted up the optic nerve to the brain. But the key thing we're talking about is the macula, which, as I explained to patients, is like the bullseye of the dartboard. It's the center of the retina, where in language we know the cones are concentrated for central vision, acute vision, and color vision. And if you like, it's the part of the retina that is working the hardest our whole life. So what is AMD? It's a progressive disease of the central retina, the macula, the back of the eye. And I know we all talk about it, and we've probably heard a lot about it, but I always try and put myself in the shoes of the patient as if I woke up the next day and this is what I saw. So AMD affects the central vision, where patients have this progressive loss, but the peripheral vision is not affected. And it's important, if you're talking to patients about macular degeneration, one of their key thoughts, even if they don't ask the question, is, will I go black blind? But they never go black blind from AMD, but unfortunately the central vision is affected, which I think we would all consider the most crucial part. And it is painless. There's patients often think loss of vision goes with pain, but it's painless. And I apologize if you're hearing anything in the background. It's because of these 5 in the house. And you know, macular degeneration must be terrible when it takes away the most precious things in your life, because once the vision is lost, it's irreversible and can't be regained. So what happens at a physiological level with macular degeneration? That a reminder that at the macula, or throughout the eye, we have the retina. The last cellular layer of the retina is the RPE, or the retinal pigment epithelium. And then below that is the choroid, which is the vascular layer. So basically there's 3 layers. There's the retina, which is the film in the camera, the choroid, which is the middle vascular layer to keep everything alive, and then the outer white layer, the sclera. But the RPE is the key player in macular degeneration, in that it has 3 important functions. It nourishes the retina. Very important, it removes waste products from the retina. So I explain this to the patients as the RPE is like the garbage truck. It takes the waste products away. And that's of the visual cycle, the turnovers from the rods and cones. But then importantly, it's also a barrier that stops blood vessels coming up from the choroid up into the retina. So a normal retina, we have the photoreceptors and the other layers of the retina, the RPE, Brooks membrane, and then the choroid, the vascular layer. So with macular degeneration, we've simplified the classification into early, intermediate, and late macular degeneration. With early and intermediate, which is 85% of cases, there's drusen present, which I'll explain what that is. And 15% are late severe cases. Out of those, about 5% is atrophic dry AMD, which is devastating for the patients who have that. And 10% is the exudative or wet version or neovascular version of macular degeneration. So in early and intermediate AMD, and at this stage, a lot of patients actually don't even know they have macular degeneration, which brings in the importance of regular eye tests. But at this stage, this is where the drusens start to build up. So basically, again, as I explained to patients, if the garbage truck doesn't come every week, the garbage piles up on the street. And that's what the drusen are, the drus are, is that the RPE no longer functions like it should, and the byproducts build up and start to form this pathology between the RPE and the choroid. In the early stages, the drusen can be very fine, and in the intermediate stages, you start to get larger drusen and possibly starting to get some visual change for the patient. But a patient who has early fine drusen like this is probably not experiencing any visual concerns at all in the picture on that side. Coming to the late stage AMD, this is where it starts to get more severe in terms of the vision. And this is a devastating condition, atrophic dry AMD, for the patients who have it, because basically there's a gradual loss of the photoreceptors and accordingly a loss of the vision, and there is no effective treatment for this. This is 5% of cases. And I'm just outlining there, I know it can be difficult to see, but you might see there's the paler orange area there and there, which is the geographic atrophy. At this stage, this is the patient who still sees a bit centrally because the fovea is preserved, but immediately around their central vision, there's scotomas or loss of vision, which obviously makes it hard if you're looking at a word, because you might see the central letter, but you don't see the letters either side. And eventually that unfortunately usually involves the fovea and people go legally blind with no treatment. Now coming on to the other form of late stage AMD, the neovascular or commonly called wet AMD. This is where, again, I like to put it as how I explain to the patients, is you start to get cracks through the pavers and the weeds start to grow up. And in the eye, the weeds are bad blood vessels growing from the choroid. So that's the neovascular tissue that comes up through Brooks membrane, up under the RPE, up through the RPE and then under the photoreceptor layer. And you can imagine, just like ink under the film and the camera, this starts to have devastating effects on the vision. And clinically, we see submacular hemorrhages. It's not always a hemorrhage for exudative AMD, but there can be subretinal fluid or intraretinal fluid, but hemorrhages are common as well. And this is when the patient has a sudden loss of vision. And they may not have even seen an optometrist or ophthalmologist before and may not have even known they had any level of macular degeneration, and then all of a sudden wake up with this affecting their central vision. So particularly for the later stages of AMD, these are the sort of symptoms that your patients might be mentioning at the counter. So any of these are ringing alarm bells in terms of checking that the patient is having regular eye reviews or has had any eye reviews with an optometrist or ophthalmologist. But if they start to report any difficulty with central vision, so difficulty reading, distortion, where they'll report that the telegraph poles or the fence posts are wavy, or particularly dark patches in the center of their vision, then any of that needs to be seen quite urgently. So to give you an idea of what a patient would see, normal vision reading an MDFA newsletter versus macular degeneration where it's severely compromised in the center in the late stages of the disease. Just to give you an idea of other things, patients often report general blurring of vision, which is usually due to cataract. And glaucoma is the tunnel vision where the peripheral vision is affected, but the central vision is preserved. So it's the opposite of macular degeneration. And then diabetic retinopathy, the scotomas can be anywhere depending on intraretinal fluid or hemorrhage and so on. So what are the risk factors for AMD? The first key one, why we call it age-related macular degeneration, is age. So 1 in 7 people over 50 have it. So I say to the patients, look around the shopping centre, 1 in 7 people over 50 have it, whether they realise it or not, and 1 in 3 over 80. So the incidence increases with age. Family history is very important. So it's in my family, my mum has it and my uncle has it. So I have a 50% chance of developing it. And anyone who, if I see any patients with macular degeneration, one of the things I always do in the initial consult is check that their family are having eye tests as well, particularly family over 50. Patients often ask, is there anything I can do to reduce the macular degeneration? And really the one, or a key modifiable factor is smoking. So if patients are smoking, they have 3 to 4 times the risk of developing AMD in the first place, and it's usually more severe. And I see that clinically in patients. Stopping smoking does reduce the risk over time, just like other pathologies like lung cancer. So patients will always ask, is there a treatment for it? And unfortunately at present, there's no cure, but research is continuing all the time, particularly CIRA, Centre for Eye Research Australia in Melbourne, is doing excellent work with retinal stem cell therapy. And there's also gene therapy. But for dry AMD, there's no definitive treatment yet. But this is where diet, lifestyle, and sometimes supplements are important. And we'll be discussing that a bit more later. But for exudative AMD, thankfully, a treatment has become available, and I'm sure you're all aware of the anti-VEGF agents, which I'll mention in a moment as well. But the treatment became available first in Australia in November 2008, January 2009, and it's changed the face of exudative AMD. But always remembering to educate the patients on diet and lifestyle as well. So as we mentioned before with the exudative AMD, this is where the intravitreal anti-VEGF injections have not only changed the face in Australia, but all around the world in terms of this disease. Because if we catch a patient early enough, which comes back to the urgent referral if there's any central eye visual symptoms, often their vision can be pretty much fully restored. But if it's either caught late, the patient's had it for a couple of months, or there's a lot of damage from a hemorrhage, it'll stabilize the disease, but it's hard to get improvement back. And there might be questions later on the frequency and dosing and how we treat patients individually. But just to say, there's 2 key agents, Lucentis and Eylea, or ranibizumab and aflibercept, Avastin, which for ocular use is currently, the stocks are in short supply and production has ceased for some number of reasons. And there's a third anti-VEGF agent that's here now in terms of PBS. So Lucentis, Eylea, and Beovu are all on the PBS. Avastin's off-label. Beovu or brolucizumab is not used as commonly yet due to some concerns about adverse side effects. But how has the anti-VEGF revolution affected rates of legal blindness in AMD? This is a graph that's commonly used in terms of, it was actually in Denmark where Europe got their approval earlier than Australia. But basically, the top graph is legal blindness due to ARMD. The bottom graph is legal blindness due to other causes. And you can see that when the anti-VEGF agents came in, basically the rates of legal blindness due to wet AMD just started falling off a cliff, whereas the other causes stayed about the same. So it's been a remarkable revolution all around the world. We say a third of patients improve vision, a third the vision remains the same, and a third still have some decline, but we're finding that to be less and less because patients are becoming better educated through great work like with the MDFA. So they're going, having an appointment earlier if they have visual symptoms. And overall, 90 to 95% of patients have better outcomes than if they had nothing. But it really caught early enough. I can't emphasize that enough. If the patient is caught early enough, by that I mean soon after they've developed the exudative change. I mean, I've had patients now for 10 years plus who are maintaining 20/20 vision, 6/6 vision, who 9 years ago would have been legally blind if it wasn't for the advent of anti-VEGF. So if patients, the disease is detected early, they have a great outcome. So what should the patient do? What should we be talking to them? We should be saying have regular eye tests and do not ignore any symptoms. Patients tend to have this urban myth that if I'm getting older, my vision should be getting worse. That's not the case. At any age, if the vision's getting worse, there's a reason for it. So people should have it checked out. The Ansler grid is one of the best tools in ophthalmology. And, you know, one of my aims I would keep thinking about, and this is with the MDFA that I've spoken to the team about previously, it'd be great to somehow have an Ansler grid in every household in Australia, just like the Gideons put a Bible in every hotel room, because it's such a simple test for people to do once or twice a week to check their own vision, where you cover one eye at a time. And I tell patients to put it on the fridge, and Monday morning when they grab their milk, so they're arm's length, they glasses, if they wear their glasses for that distance, then one eye at a time, just check their vision, make sure there's no central distortion, and they can get on with their week. But if there's any central distortion, obviously contact us immediately. Lifestyle, diet and supplements is important as well. And Geraldine, Associate Professor Moses, will talk more about the supplement side in a moment. And the last thing I just wanted to mention, this is something that it's important we're all aware of, a syndrome called Charles Bonnet syndrome, because not uncommonly when patients are legally blind, their visual cortex can try to generate images, and the patient has visual hallucinations. And it can be anything from bizarre shapes or colors to, I've had patients who could see, so they're legally blind, but they swear black and blue they could see dogs or cats or little children at the back door and things like this. But the problem is the patient's legally blind, they're elderly, then they start to have visual hallucinations. And a lot of them actually start to think they're getting dementia. And they're scared to tell anyone about these visual hallucinations because they're worried they might end up, you know, the family putting them in a home and so on. So I make sure all of my patients with late stage disease are aware that this is a possibility. And if they have any visual hallucinations, to tell me, not to worry about them. And I think that's important they all know. So basically, that's the overview of macular degeneration, the types of macular degeneration, the causes, the symptoms, and the treatments available. And at this stage, I'd like to hand over to Associate Professor Geraldine Moses, whom I'm sure a lot of you know, who will be talking more about the use of supplements and how pharmacists can help patients with AMD. Thanks, Geraldine.
Thank you very much, David. It's great to be here, and thanks to everyone who's online tonight joining us. It really is great to have this overview of AMD. It's extremely common, as David experienced. I also have had AMD in my family. My mother had it very badly, and she passed away last year, but in the later year or so of her life, she was seeing little children everywhere, especially climbing the Christmas tree, which was interesting. I'll just get my slides up. And I need to go back to the first slide. So because people purchase the supplements that are marketed for use in a lot of eye conditions, but particularly macular degeneration or AMD, it's important for pharmacists, indeed all health professionals, to have a clear understanding of their place in therapy. They do have a place, and this is one of the few times in the use of supplements when we have really good research to support what we say. It's quite rare, isn't it? You know, most of the time we're flying by the seat of our pants. So let's just recap just quickly about the fact that there are two main types of AMD. Dry is the most common, but there is no treatment. You don't use the injections, the anti-VEGF drugs, to treat that form of AMD. It's only used for the wet form, which is about 10% of cases, but it's the most devastating, and it's responsible for 90% of the legal blindness. And it's due to this neovascularization, the blood vessels growing up through the choroid and the bursting in, and they become leaky at first. So they leak fluid into the retina, and the lumpiness of that fluid can cause is what makes straight lines suddenly look bendy. And it's the purpose of the anti-VEGF drugs is to shrivel up those blood vessels, and that will hopefully then take the fluid away and make the blood vessels stay away for a good period of time. So and as David said, there are 4 sort of levels of the disease, which are now called none, early, intermediate, and advanced. And the wet is always considered the advanced form of the disease. And the key thing is, though, that it can happen suddenly. People will manifest with these symptoms, as you heard, and we in pharmacy or any other place where people are talking to you, back garden, wherever, but if people, especially in pharmacy, because people present and just come up to the counter and start talking, and they don't have to make an appointment, if they start to describe these sorts of symptoms and they haven't considered that they should go and see an eye health professional urgently, then that's the really useful role we can play to make sure they see this as a medical emergency, and they need to waste no time in getting assessed and hopefully accessing treatment. The day my mother first experienced wavy lines in her vision, she rang me about half an hour later and said, "I can't see properly." And we had her at an ophthalmologist's office within 2 hours. And she had her first injection of an anti-VEGF drug within 3. She didn't like it, but it certainly did halt the immediate progression of the symptoms. And she was able to be on those injections for about 5 or 6 years. So the thing is, everyone says then, so I might be having these injections, but what's the role of vitamins? Or I don't have AMD, but my mother does. I wonder if I should take them. I'm sure you've all faced questions like that. So let's just quickly go through the evidence that we have. There were 2 pivotal studies. They're called the age-related eye disease studies. The first one was published back in 2004. So it was conducted for 5 years before that, a long time ago, but excellent study, and really helped firm up the knowledge about what role supplements might play in this disease. There were supplements containing vitamins A, E, and C with copper and zinc. And it's important. And it went over 5 years, and there were 4,500 patients, all at different stages of the disease. So importantly, it must be recognized that everyone declined over that period of time. No one got better. No one's disease stopped. So this is what we have to convey to patients, that if you take supplements, it's not going to stop the disease, and it's not going to make you better or give you your vision back. And definitely the people in the early stages of no disease or early disease, there was no benefit. They progressed at the same rate. There weren't that many of them, but they progressed at the same rate as those on the vitamins or not, wet or dry. But there clearly was a benefit for people in the intermediate group, and it slowed the progression from intermediate to advanced by about 25% over the 5 years. Now that's fantastic, because at the time there was absolutely nothing people could do. That if people were diagnosed with AMD, they would just go, "Sorry, you'll probably be blind soon." There's just so little they could do. And many of the risk factors were known, such as smoking, exposure to ultraviolet light. And again, it's all too late then, isn't it? It would be good to stop smoking. That would probably help with preventing further progression. But that's one of the problems, is that the supplementation of vitamin A in this range of vitamins and minerals has always been known to be associated with increasing the risk of lung cancer in smokers. And so there are a lot of people who are smokers who then develop AMD. So some of the controversy about this research has been that it did prove that there was increased risk of diagnosis, not an enormous amount, but enough that you'd say, well, would I take these vitamins if they're going to give me cancer, lung cancer? So the next study, the AREDS2 study, replaced the beta-carotene with lutein and zeaxanthine. So these are retinoid type compounds in plants, and you would have seen them in lots and lots of other products for eye disease out there on the market. And this study also looked at the role of omega-3 fatty acids. Oh, by the way, with AREDS1, they also looked at the benefit for cataract, and they found no benefit to reducing the incidence or progression of cataract with the AREDS1 use. And they also didn't take any of the formulae we would see in Australia. I put Ocuvite on the slide so you could know that's an American brand. It's made by Bausch & Lomb, and it was that product that they took, which we'll get to, but it's twice the strength as most of the products available here in Australia. So getting back to the AREDS2 study, they had, again, about 4,500 or almost 5,000 patients in different stages of the disease. They replaced the beta-carotene with the lutein and zeaxanthine. They threw in some omega-3 fatty acids and kept the copper and zinc. And they found very similar results over 5 years, and found that this formula was not superior to the AREDS1 formula, even though the products you might see around are called something plus. They were the same. So it gave a similar degree of benefit, slowing down progression for people with intermediate to advanced disease. No benefit at all for early stages. So if you don't have AMD or you've got early AMD, it will not help. And they found exactly the same with this formula. And but they did use lutein and zeaxanthine instead of beta-carotene. So that was great. They could say we can ditch the beta-carotene, which has got the risk for smokers. And that's a benefit, isn't it? Because many smokers are going to get AMD. And then the omega-3 fatty acids, they found no benefit at all. So we've ditched them as well. So now you can, if you see products like MacuVision Plus that are based on this second formula, their benefit is not that they are more effective. Their benefit is that they are safer for smokers because they've got the different carotenoid. Does that make sense? I hope so. So if you want to go, without having to read all the studies word for word, you want to go to some nice summary sites. The best one would be the NIH in the United States. Go to the National Eye Institute website online, and they have some fabulous summaries of these two pivotal studies, and also the sub-publications that they put out since then about their other findings. And as I've just said, sort of they say about both AREDS1 and 2 showed that reduced the risk of progression for the intermediate and advanced. They don't prevent the onset. They don't help slow it down when you're right at the very start. They don't benefit cataract. Omega-3 fatty acids don't help either AMD or cataract. And for smokers, the formula with the beta-carotene out and the lutein zeaxanthine in would be more safe. So let me show you the formulae. This is a key issue, especially for pharmacists, because we obsess about dose. I'm sure everyone else does, but I would leave for everyone. Many of you have probably heard this before, and there's a lot of well-known ophthalmologists who repeat this message a lot too, that we have to make sure people are taking the equivalent of 2 tablets of the Australian formulations that you see. So I'm going to use the MacuVision products because they are the most famous. But in this box with the skinny green outline, these are the AREDS formulae. The first one with beta-carotene in it, and the second one without beta-carotene but with lutein and zeaxanthine. So have a look at the MacuVision product. It's got no beta-carotene, it never has. Now, whether that's because they were really clever and didn't want to give smokers lung cancer, I don't know. But when MacuVision first came out, we had to tell people, if you take MacuVision, you need to add a beta-carotene product in. But also it's half the strength. So see, the vitamin C dose is 250 milligrams. For the AREDS formula, it's 500, and so on. So if people are taking Macuvision, they need to take 2 of them to even try to match the outcomes of the AREDS research. With Macuvision Plus, it's very similar strengths, but we've got now the lutein zeaxanthine thrown in there, but similarly, it's half of what you need. So this is what we have to tell people, and I'm sure you've all seen it, people who only take 1 a day, and that's what's on the bottle. Why is that? Well, my understanding is that it's because of the zinc content. If they had put 80 milligrams of zinc in the formulation, that would have made it a Schedule 4 prescription only medicine. And that just would not have sold. People wouldn't be interested in taking it as they are now. So they just said, fine, that's what we're going to do. But hopefully everyone will tell them that they should take 2 a day, but they put 1 a day as the dose on the bottle, which is not the dose that will match the research. In the UK, in about 2014, they got very nitpicky about how much money was being spent on the vitamins, and that people were not on the supplements, and people were not being very nitpicky about having realistic expectations for the supplements. Indeed, it was sometimes putting people off accessing more appropriate treatment like the anti-VEGF drugs. So they said, we're spending £1.6 million of the public purse on supplements. People can really pay for this themselves. So they took it off the NHS. And also, they felt that the degree of benefit was really quite small and not worth the public expenditure. We don't have Macuvision on the PBS here, so it's really not heresy to say that, but it's interesting to know that it had been on the NHS in the UK and they took it off. But also it's important for us to remember that supplements are not lollies. Any of you have heard me speak before know I say this a lot. I had an article in Australian Prescriber last year on the potential adverse effects of vitamins and minerals. I use this mnemonic A, B, C, D, I, F to remind you of the 6 potential harms of any drug, but it's very useful for supplements because often people think there aren't any harms. It's all just benefit. And although, you know, sometimes the benefits can outweigh the risks, it's important to think of both sides of the equation. And clearly for people with an intermediate AMD, there would be considerable benefit. But for people in stages 1 and 2, no disease and early isn't. So why take these risks? So see how you've got to weigh up risk and benefit all the time, but that equation will change depending on what else is going on. So the sorts of things we need to think about would be like adverse effects. You've heard about the increased risk of lung cancer with beta-carotene. That's also been shown with other forms of vitamin A, but luckily not the lutein and zeaxanthine. In the AREDS 1 and 2 studies, they did identify a slight increase in the risk of prostate problems. They called them genitourinary symptoms. They're mostly related to male, mostly about prostate enlargement. And that's also been known about zinc in other studies, in other settings. So if it led to hospitalization, that's somewhat concerning. So you would want your patients to know that and not conceal the evidence that there might be an issue. If you've already got things going on with prostatic hypertrophy or whatever, if they want to take this, maybe that should be more closely monitored. Also remember that with mineral supplementation, we always see people get things like taste disturbances, a no-brainer. With zinc, you get a metallic taste in the very first dose. That the reason why copper is added into the formulation is to compensate for the zinc, because if you take a lot of zinc, you can induce a copper deficiency. So it's not there for any particular therapeutic benefit to the AMD. It's just there to balance out the zinc. But both can cause taste disturbances, and they can also interact with lots of drugs, can't they? Pharmacists know this is a grade 1 pharmacology, but the list of potential chelating interactions between minerals and a lot of conventional medicines is getting longer. You would know a lot of these already. Don't forget bisphosphonates, they're used a lot. Other minerals interact with minerals because they compete for the same transport sites in the intestines. Like calcium and magnesium, they compete, so you should always take them separately. But zinc and iron will compete with each other. Clearly zinc and copper might too, but that's the idea. So just remember that and make sure you don't just throw these vitamins at people without checking that it might interact with their usual medications. And what they might need to do is separate their administration out by 3 or 4 hours. There are other things to think about, such as the antioxidant effect of the vitamins. They're in the formulation for their antioxidant benefit, but antioxidants aren't always a good thing. And an area where we always have to be very careful is in oncology. I work in oncology when I'm at the Mater Hospital, where I work 2 days a week. We have a standing rule, that when people are on conventional chemotherapy, part of the mechanism of action of that form of chemotherapy is that they are pro-oxidative in how they make cells break up and die. And if you then take an antioxidant at the same time, there's some evidence, not an enormous amount, but some, that's persuasive that it could impair that efficacy. So we just say, it's not like these are life-saving medicines. Take them some other time. You can still take them, but just not the day you're having chemotherapy. So that's important with conventional chemotherapy. There's actually some good evidence that drugs like bortezomib, which is, in fact, I can't remember its actual mechanism of action, but ascorbic acid, even in lowish doses, competes for the receptor site for bortezomib. So that's an interesting thing. Again, they could be on Macuvision and not realize it could be interacting. And also, we've always known that there are potential interactions with vitamin C and estrogen absorption. But what happens is that it increases the estrogen absorption, not decreases. It makes more get in. So you can get more of the estrogenic side effects if you take vitamin C at the same time. It prevents the sulfation of the ethinyl estradiol and lets more get absorbed. So again, if they're separated out by 3 or 4 hours, it'll be fine. Just don't take them at the same time. So it's stuff like that we have to remind people of. So getting nitpicky about the benefit, make sure they have a realistic benefit and legitimate reason for using these supplements, and also checking out potential adverse effects from drug interactions. And remember, we've got these amazing anti-VEGF drugs. There were 4 on this slide, but I took one off, but I forgot to change the 4 to a 3 at the title. But they're inhibiting vascular endothelial growth factor to shrivel up those blood vessels and make them go away. And that benefit is incredible. And you wouldn't want people thinking vitamins could do the same, but they can do their own little bit. So bottom line is that we as health professionals, we're not there to give people permission to take these supplements or not. It's about helping them make a more informed and safe decision, weigh up the risk versus benefits. And if they're gonna take an ARID supplement, make sure they take the right dose. Thank you very much.
Thank you so much, Geraldine. That was fantastic. Really great overview of ARIDs and all of the possible interactions. And I think there's going to be some great questions about that later on. So I'd like to now just invite all of you just to enter any questions you have into the question box. We already have a few in there. It'd be great to get a few more. And while you're doing that, and Geraldine and David are having a little drink, I'm just going to talk you through the reason why the Macular Disease Foundation exists. So we really exist to support people living with macular disease around Australia. We're the peak national body for Australians with macular disease, not just AMD, but also diabetic macular edema and the other more less common forms of AMD or macular disease. And sometimes when clinicians, I'm an optometrist, when we first diagnose someone with AMD, it's quite overwhelming. Often in the early stages, they're asymptomatic. They have no idea what's going on. And so it's a bit like visiting an overseas country back in the day when there was no internet and we couldn't go and Google search everything. So they've heard a lot of new language. They don't know the context. They may have baggage, other ill health and economic issues at home. And so it's a really overwhelming time. And more often than not, they leave the optometrist's room with more questions than they arrived with. And that's where the Macular Disease Foundation is really useful. And you're, of course, also going to come across these same people in your pharmacy. People who've been to the optometrist, they heard that they needed some vitamins, they weren't quite sure which ones or how often to take them. They may have questions for you. And so this is why this type of education is being held tonight. So in terms of looking at the types of supports that the Macular Disease Foundation provide, is very much about individualised support. So we assess where the patient's at, or the client in your case, and we try and make sure that we give them the types of information that's right for where they are in their journey. So somebody who's very early on in their AMD journey may not necessarily want to hear about intravitreal injections, but they may want to know about what they can do to reduce their risk factors, who they should tell, should their family members get tested, what dietary and lifestyle changes can they make. So that's the type of information that we then talk through with them. We also provide them with lots of resources, both online, through webinars. We still do face-to-face talks around Australia as well to increase awareness, but also just to inform. In addition to that, a lot of our conversations with patients are about nutrition and lifestyle changes, and particularly smoking, quitting smoking. We know it's the only modifiable risk factor for AMD. And currently we have been developing some different types of peer support programs. In the last 2 years, MDFA has branched out from a telephone peer-to-peer support group where a MDFA volunteer who's trained and living with AMD shares their experience with a newly diagnosed patient by phone, to now we have face-to-face groups all around Australia where people can share their lived experience, which is incredibly powerful. But they also get great tips from each other about things that they can do to modify their lifestyle. And often they can also create a little bit of questions, and those people may come to your pharmacy for clarification as to, well, I only take one of those tablets, and should I be taking two? So there's a lot of scope there. And of course, a lot of our work is about helping people to navigate these new systems that, as they're being diagnosed with a chronic disease and as they're moving into the older age, particularly if they have vision loss, it's really hard to negotiate those government services anyway, and especially at that time of their lives. So you may come across these types of people in your practice. You may have somebody who really wants more information, or somebody who wants to improve their health literacy, or somebody who needs help to access supports and services. You can very quickly refer patients to MDFA via our website, and there's a referral page which really takes less than a minute for you to fill out. And then they will receive a call from our services team, who are all vision scientists, within 3 working days. And on that phone call, we establish where they're at, what they want to know, and start the journey with them. Now, we also know that it's a time when pharmacists are being asked to do more and more with less and less time. So MDFA are very keen to support you in your work. So one way we're doing that is, for those of you who may have an interest in eye disease, we encourage you to subscribe to Macular Matters, which is a quarterly e-newsletter, which is a really quick read and an update of what's happening in the macular disease sector. You can access it via our website or via the QR code now. Excitingly, in 2019, MDFA were granted 1.5 million by the Commonwealth as part of the Strategic National Action Plan for Macular Disease. And what this grant has enabled us to do is to develop education, which is accredited by all of the different member organisations for optometry, for orthoptists, and now pharmacists and GPs. So the pharmacist education is now ready and accredited. It's already available on the MDFA website, and it's at no cost. And essentially it's been developed in conjunction with APRANSCO, Optometry Australia, PSA, and various other parts of the consortium. So you can access this education if you have a particular interest in eye disease and would like to know more. There are 2 modules, one on age-related macular degeneration and the other on diabetic eye disease. And then the last thing is, if you in your practice would like to have some resources on potentially the nutritional information around ARIDS, about making changes to diet and lifestyle, if you would like a supply of AMSLA grids so that you can perhaps, you know, if somebody turns up at the counter with something's just not right with their eye, you can do a quick little check of the macula and send them off to the optometrist. these resources can be accessed through our website, www.mdfoundation.com.au. So now I'm going to invite David and Geraldine to rejoin us, and we are going to go to the questions. We have a heap of questions. This is so exciting. The best day ever. I'm just going to smooth that around so you don't all have to look at that. Let me just stop sharing for a moment. There we go. All right. So first question, what is the relationship, if there is one, between age-related macular degeneration and diabetic edema of the retina?
I'll answer that one, Geraldine. No, pretty simple answer, no relationship. As in one doesn't particularly influence or affect the other. If someone has, some patients do have dual pathology of diabetic macular edema and exudative macular degeneration, but fortunately both of those pathologies are amenable to intravitreal anti-VEGF therapy. So the same treatment is for both. But if the question is, does one clinically affect or influence the other, the answer would be not really.
Thank you. Does blue light contribute significantly to AMD, David?
The research on that would be equivocal at best. I mean, if we're talking about limiting screen time, I'll tell my kids every day that blue light affects their eyes and they're not allowed to be on their screens and et cetera, et cetera. But no, I think equivocal would be the best response to that, as in there have been some studies suggesting it. There's been others showing no importance. It was about 2005, I think, some intraocular lenses were manufactured for which had a yellow tint to filter out the blue light. And pretty quickly they phased out because the patients didn't like the fact 24/7 they were seeing the world through a yellow tint. So those lenses didn't. But if people, I do have a theory on sunlight and eye and so on, as in I think it's just wise to wear polarized sunglasses whenever you can to filter out any amount of light coming into the eye. But no, there's no firm phase 3 trials or anything that would say that blue light either causes or exacerbates AMD.
I have a question for Associate Professor Moses. One of the questions that often comes up in the education talks that we do around Australia is, I always warn people that before they go and have kale smoothies, they should talk to their GP. And that's supposedly due to the interaction between vitamin K in the kale and warfarin. How much kale would they need to be having to have that type of interaction? Is that a likely scenario?
It is actually. And I don't think you're going to get very far with the consideration of how much kale, because you'll just drive yourself mad. So rather, I think just remember that warfarin interacts with everything. Just, as soon as you start on warfarin, all the things in a healthy diet are likely to influence it. So it's probably more doable to simply say that if you could just ingest a moderate amount of lovely healthy things like green leafy vegetables, but giant smoothies full of kale probably isn't moderate. So maybe only have a small smoothie. I think the other thing to say though is that no one's on warfarin anymore. Everyone's on the DOAC, so it's not as big a problem as it used to be. And if you are on warfarin, it can be just monitored more closely. If you decide you want to have a health kick and try the kale smoothies for a week, or perhaps during that week you should more closely monitor your INR just to see what effect it does have.
That's great, thank you. This question could be either of you. Someone's heard that saffron is also beneficial? Is there any research regarding this? Does either of you want to answer that one?
Did you want me to say anything, Dave? Have you got anything up your sleeve?
I can say what I normally say to patients.
I do, yeah.
And it's the same with other things like saffron, bilberry. Commonly, there are questions are asked about, will these help prevent macular degeneration or help slow down macular degeneration? And what I explain to patients is any evidence is anecdotal at best, that basically I have a theory too. If something's working for you, keep doing it. So I don't denigrate it, but I say to the patients, can I put my hand on my heart and say that I can quote you some scientific study that says that it's beneficial for macular degeneration? I can't do that. But on the flip side, I don't think it's detrimental either. So if patients want to take it, that's fine. And as a side point, there was I think it might have been a few years ago, Sabine, at the MDFA, might have been before your time. There was, the MDFA did a good job of, there was a university in New South Wales, I won't mention the one, that an academic was putting up a lot of studies about saffron and its benefit for the eye. And the same academic and website just happened to be selling saffron products to the patients or to the readers as well. So the MDFA shut that down on the basis of there's no scientific evidence to prove it. So you shouldn't be touting it to sell a supplement.
I will just add something if that's
Interesting.
okay. In that 1.5 minutes, I got to do a quick little look on PubMed to see what's there. And so there is some research, some studies looking at the role of saffron, but the numbers are extremely small. One promising looking study from 2016, published in 2016, had 60 patients, but they don't say how they differed in terms of their progression of the disease, wet versus dry. And the benefit doesn't seem to have been in terms of preventing advanced disease, but more about preserving the retinal pigmented epithelium. So yeah, I'd have to say there is some research, but it's preliminary. And let's not forget that usually it's about trying to flog a product. And because I talk about drug interactions a lot, it may feel like there aren't going to be problems in taking things like a bilberry supplement or a saffron or a marigold supplement, but there are lots of drug interactions. So make sure you check that out.
Because I think the big thing is all of the treatments we try and give are based on evidence-based medicine. And yeah, I think with those sort of trials, with only 60 patients, I don't think they really sort of cut the mustard in terms of high-level evidence-based. And bilberry's in the same category. But,
yes, that answers somebody else's question. Somebody just wanted to clarify that they were concerned that does ARIDS and ARIDS 2 that the trials found no benefit with the supplements for wet advanced AMD. I think it was a slowing in the progression of AMD, but that is a benefit. Is that right? Did anyone want to comment on that one?
Well, I've always actually wondered this myself, that once you're at the end of the line at the latest stage and it's advanced and it's the wet one, is there any benefit at all? What do you say to patients, David?
If they're on anti-VEGF therapy, then no, I don't recommend macular supplements. Or,
what if their other eye is intermediate? Would you then recommend it, David?
Correct. So for in terms of the actual, was the participant asking if they've got exudative AMD? If they were exudative AMD, say in both eyes, no, I wouldn't recommend necessarily taking supplements. But yes, in answer to your question, Sabine, if they're intermediate in one eye and exudative in the other, they're the ones that I would recommend to have the supplements. So anything below intermediate AMD, I don't recommend supplements, but purely based on the studies. Again, evidence-based medicine.
Yeah, thank you. So if a patient has been advised that changes to their visual field in line with early AMD symptoms like waves or gaps are the result of a wrinkle in their macula that will resolve spontaneously without treatment, how long should they wait without symptom resolution before they seek further advice?
I'd like to know which ophthalmologists or optometrists are saying that wrinkles in the retina might spontaneously resolve. The only thing I can think of there people might be thinking of, so totally different. As I explained to the patients, the macula is one part of the body, but there's a million things that affect it. That's why there's textbooks, left, right, and center on it. So a wrinkle in the retina most patients would probably be trying to describe an epiretinal membrane, which is effectively scar tissue or glial tissue growing over the macula. So that's one of our most common operations, is through vitrectomy, peeling off the epiretinal membrane. So that's the main thing that causes a wrinkle in the retina, but it doesn't spontaneously resolve. It's only with surgical intervention if it's needed.
Yeah.
I'm not sure. Did I miss part of that question though?
No, I think that was good.
Yeah. So no association with AMD.
Yes. And I think the good thing always is if you have any clients presenting to your pharmacy with any types of symptoms that they're concerned about, go and see your optometrist or eye specialist. No, don't wait. It's always good just to go. And that's why optometrists, not to push the barrow here, David, but optometrists are very accessible if patients don't have an ophthalmologist.
Oh, yeah, absolutely.
Optometrists are primary health eye care providers, and we can triage people and get them sent much more quickly to someone like David. So it's really good to do that.
Oh yeah, no, my wife's an optometrist and my sister-in-law is Sabine, so I'm very on board with optometrists. It's how it should be with ophthalmology and optometry. Or basically, the important person is on the other side of the slit lamp, not us. So yeah, the quicker they get seen, the better by whoever, for sure.
Fantastic. Now we've got a couple more questions. Are you both happy to whiz through a few more?
Yeah.
Sure.
Are Lucentis and Eylea injections likely to be the mainstay of treatments for the foreseeable future, or are there other treatments coming online in the medium term?
So there's been research for a few years now, trying reservoirs of anti-VEGF. The problems there are it's more of a surgical procedure to implant it. So this is where through a vitrectomy procedure, a little pellet, if you like, containing anti-VEGF is put into the eye, and then it releases the anti-VEGF over the 6 months or so to try and reduce the number of injections. But the problem is the procedure's still got too high a complication rate at present in terms of things like vitreous hemorrhage, retinal detachment, and so on. So in answer to the question, I'd say yes, for this foreseeable future, they're the mainstay. And then, as I mentioned in the talk, there's the third anti-VEGF, the Beovu, that's now PBS listed. There were some concerns regarding adverse side effects in the initial trials, Hawke and Harrier. And but if you were talking about the majority of ophthalmologists in Australia, Lucentis and Eylea are definitely the mainstay.
Mm-hmm. Great, thank you. We've already touched on this one a bit also. How aware are patients of what stage of AMD they have? And are optometrists able to identify AMD stages, or do they need to see an ophthalmologist?
Oh, Sabine.
I'm trying not to answer that one.
Just kidding. No, of course optometrists can. So the early stage, intermediate, and so on is based on the size of the drusen per the studies, and of course optometrists and ophthalmologists can both, both assess that just as well as each other. I think in terms of other patients aware, remembering that we're dealing usually with lovely 80, 85-year-old, 90-year-old, my lovely patients, I call them my lovely oldies. I really enjoy dealing with the senior patients. They're probably not as caring as much as whether they're intermediate or stuff like that. They just want to know, David, do I have dry or wet? And do I need injections? Because when they're talking to the neighbours and people in the shops and people at the bowls club and so on, they know people who are getting injections, and they really just want to know, am I dry or wet? And I do make a point of telling people if they're very early dry and, they're very, their stage there, or whether it's quite advanced, but I don't get into size of drusen or anything like that with patients, because I think that just confuses the matter for them. Mm-hmm. But for us, optometrists and ophthalmologists, what stage they're at determines the treatment protocols as well.
Yeah, great. So 3 more questions, and then I think we might need to stop there because it's we're going a little bit over time. Somebody's just saying, thank you so much for the great presentation. I had a question about the anti-VEGF therapies and their risk of atherothrombotic events. Would patients normally be commenced on an antiplatelet or anticoagulant for this?
No. So there was, Geraldine, I'm talking too much. Is there
That's
anything?
fine. You speak. I don't know. I mean, you don't see people on antiplatelets just because they're on an anti-VEGF, do you? But
no, correct.
Yeah, it's only if they were to get some sort of clot.
Yeah, correct. So no, there was initially when Eylea was introduced was some concern regarding was there a minimally higher risk of adverse side effects such as strokes and so on, but that was relatively quickly dispersed, and no, there's no need to put patients on anticoagulants or anything like that. And in fact, the reverse question was asked: do anticoagulants make exudative AMD worse, and should people stop anticoagulants when they're on when they have exudative AMD/intravitreal anti-VEGF therapy? And the results of the research into that was no. So if a patient's on an anticoagulant for a good reason, then they should continue. But if they were sort of taking aspirin or something willy-nilly just because they read it somewhere, but there was no medical indication, then it was advised they should stop that.
Mm-hmm. Great, thank you. So what's the youngest age of a patient with AMD that you've had in your practice is one of the questions too, Jake.
Yeah, so hence by the name age-related macular degeneration. If anyone's under 50 with query, we do get sent patients under 50 with queries as to whether it's age-related macular degeneration. Usually that's more when it's, with the investigation, fluorescein angiography and so on, that's when it's more macular dystrophies. And the age-related macular degeneration, the earliest would be about 55 that I've seen, which is even generally young for AMD.
Yeah.
But if it was, say, a 40-year-old, I'd be more looking at the line of macular dystrophies, familial dystrophies, and so on, which look very much like macular degeneration, but progress very differently.
Fantastic. Apart from smoking cessation, is there any other diet and lifestyle interventions?
Geraldine?
Well, did you want to talk? You can do it.
That's all right.
I was going to say the avoiding the sun exposure.
Yeah. So green and gold is good. I tell patients to think of the colours of Australia: green and gold. Kale. Not sure about the kale smoothies, Sabine. I haven't tried one of those, but maybe I need to. Kale, spinach, broccoli, corn, all those green and gold vegetables are great. And the mantra still is everything in moderation: a handful of nuts, still some fish, exercise, and sunglasses for general wear.
Fantastic. Last question. Do you foresee a time when artificial lenses containing reservoir of drugs would be a good type of treatment for a condition, long-term conditions, rather than a reservoir like the port device? Do you imagine that we might use contact lenses or artificial lenses to deliver drugs instead one day?
Are we talking intraocular lenses after cataract surgery? Or
I don't know. It doesn't clarify that one.
Yeah. I don't think contact lenses would be the go in terms of drug reservoirs, and intraocular lenses, it's more about the anatomy there without getting into it too much. The intraocular lens is held in the lens capsule, and that's the only thing that separates it from the vitreous, which is if during cataract surgery the lens capsule gets burst, then there's all sorts of problems with possible retinal detachment and so on. So I don't think there'll be reservoirs in intraocular lenses anytime soon because of the risk of what it can do to the capsule of the lens. But a good thought. Fantastic. If you can come up with one, whoever it was, you'll retire early.
Your business idea. Look, thank you so much, David and Geraldine, for making your time in your busy schedules to provide what's been a really great thing. Great insights from both of you and things we can all learn from. I'd like to also thank you, the attendees, for coming out virtually to attend our first pharmacy webinar with MDFA. Thank you to PGA and ACP for working with MDFA to arrange this webinar for you. And for those of you who have found this webinar useful, I encourage you to complete the free and accredited courses developed by Macular Disease Foundation Australia on AMD and diabetic eye disease. They're available through your usual CPD providers, as well as the MDFA website. And lastly, you will be receiving a post-webinar evaluation survey, and we really encourage you to fill that out if you're happy to. It really helps us to ensure that these webinars are pertinent to your practice and that you find them useful and interesting. Many thanks again to both of you, Dr. Hilford and Associate Professor Moses. It was fantastic. And everyone have a great night. Thank you.
You too.
Thank you.
Thanks for being.
Thank you.
Good
Bye.
night, everyone. Cheers.